Did you know that 35% of ICU survivors reported having major symptoms of post-traumatic stress disorder, and that those who required the use of a mechanical ventilator showed substantial PTSD symptoms that lasted for up to 2 years after discharge? We'll discuss this and other interesting facts about the relationship between sedation, delirium, and post-traumatic stress disorder following discharge from an ICU with nurse practitioner and podcaster Kaylee Dayton on this episode of The Curious Professor. Hi everyone, I'm Dr. B. Welcome to the Curious Professor podcast, where I take listeners on a journey of discovery to explore the people, places, artifacts, and natural wonders that spark my curiosity. On this episode of the Curious Professor podcast, we'll explore the life and work of an ICU nurse with Kaylee Dayton. But first, a trivia question. How many patients stay in an intensive care unit in the United States annually? I'll have the answer for you at the end of this episode. I'm thrilled to have Kaylee Dayton on the show today. Kaylee is an ICU nurse practitioner, critical care consultant, and host of the podcast, Walking Home from the ICU. She dreams of humanizing the ICU through improved practices in critical care medicine. Her mission is to bring greater honesty and awareness of the reality of sedation and immobility in the ICU. When I found out about Kaylee's pioneering work, my curiosity was immediately piqued and I wanted to learn more. I hope this interview with Kaylee will spark your curiosity too. Welcome to the show, Kaylee. It's great to have you here.
I'm excited to chat with you.
Why did you decide to start the podcast Walking Home from the ICU?
Logically, I saw this huge problem in the medical community, especially the critical care world, and a huge gap in knowledge and education and awareness of some of the problems that I was seeing. But starting a podcast was not on my to-do list. And so in all truth, I started a podcast because I spiritually felt distinct revelation. I'm a God person, unabashedly, and I was just driving in my car one day, and I didn't even really listen to podcasts, to be honest. I had not gotten into that world. My life has been extremely busy, and it was just almost like a burning bush kind of moment. And it was thou shalt start a podcast, and it was almost as distinct as if I had heard the words. And I couldn't deny what I'd heard, but I was so confused because I didn't even know really what a podcast was, let alone how I was going to start it. What did I have to offer the world? Who was going to listen to a little nobody nurse practitioner? But that's why I started it, not knowing why. And then after that, more revelation came. I would wake up in the morning, have to grab my pen and paper and write down very distinct instructions that I had as far as what topics to teach, what order to put them in. And for context, this was December of 2019. So I don't know if I'd even heard about COVID at that point. Maybe whispers from China, not on my radar. So I started formulating this really ambiguous podcast, not knowing what it would be for. And I had this urgency. I had to do 30 some odd episodes by the beginning of March. I had no idea why. And I remember telling my husband, I'm like, this isn't logical. Most podcasts are not this way. They do one episode a week, one episode a month. I mean, it's very gradual. And yet I had to put out these 30 some odd episodes by the beginning of March. And I had no idea why, other than I couldn't sleep until I did. And then boom, March comes and COVID has hit. And at first I thought, well, now the world's about COVID, and I spiritually got backhanded. And it's like, God was saying, you don't get this. You're just saying these things, but you don't fully understand it if you really think that this is irrelevant to COVID. And suddenly I realized the message of the podcast and the problems that I'm identifying are even the worst for and during COVID. So here I am continuing the podcast with a much clearer vision as to why I'm doing it and where we're headed with it.
It sounds so familiar to me because I had, not that my message is as important as yours, but I had a similar experience in that I had this desire to start a podcast without really knowing exactly what it was or why I was doing it. And it became clear in the process of starting the podcast and actually doing it that it became clear what the meaning and the message and the why of the activity was there.
Absolutely. It's daunting to start a podcast. It's vulnerable, right? And I also felt like it was career suicide. I was speaking out against the medical community that I was deeply immersed in, and I was low man on the totem pole. And yet I was kind of exposing some hard things. And so I just recognized that this would be a huge career changer. So it took a lot of faith and courage, but in the end, I couldn't sleep until I did it. So I totally get you.
Tell us about your experience in the Awake and Walking ICU to start off.
Back in 2012, I started as a nurse, just a registered nurse, not just, but as a registered nurse. It was my first job as a nurse, straight into an ICU. And I knew nothing about critical care, hardly anything about medicine in general, but they were asking me questions in the interview, such as, would you be willing to walk patients on ventilators? And I was so excited about the interview and completely naive that I said, of course, yes, absolutely. Not knowing what that would really mean. I just knew that I was open to learning whatever they wanted to teach me. So I started working there and did just that. Almost every single patient on a ventilator was awake and walking. And everyone treated it so normal, so insignificant that I didn't think it was that big of a deal. I mean, they're humans. So of course they're awake during the day. They're going to sleep at night. They're going to move and walk because that's what humans do. They're adults. So it was all very logical, very normal. And so to me, it was fulfilling to interact with patients. They're critically ill, and yet you can be present with them as you talk to them about important things like, what do you want? What does life mean to you? End of life discussions. Patients were always involved in that and with their families. And so it was just a human experience. And I didn't realize how significant that was at the time. All I knew was that I loved it.
And it turned out, as you started to become a travel nurse, that was not the norm.
Yeah, after working the Wake and Walking ICU for a few years, I was in my mid-20s. I wanted to spread my wings and see what was out there. And so I took flight and I started traveling around the United States. And the first contract I took, and I had been told, I'd been warned by the nurse practitioners that I worked with that things would be different where I was going, that no one else would really be doing what we did there. But yet I had never really seen what it looked like for patients to be medically induced comas for weeks. I'd seen people sedated. The Wake and Walking ICU receives a lot of patients from other hospitals. When they have failed, they're not getting better, then they ship them to us. And so I had definitely seen what it was looked for them, like for them to be confused and weak and things like that. But I had never seen what I saw. So I go into these units, and in the middle of the day, the lights are dim. Everyone is in bed. Whereas the Wake and Walking ICU, most people are up in the chair, even on the ventilator during the day. The lights are bright. The windows are open. There's commotion. The family's at the bedside. The patients are walking laps around the halls during rounds, just throughout the whole day, because there were 3 mobility sessions during the day and night. So seeing this place that was just dark, and it just seemed inhumane. And then what really hit me was that I couldn't talk to my patients. I didn't know who they were. I mean, I knew their medical history, I knew their diagnosis, but I had no idea who they as a person were. And that felt really wrong to me because I am a people person. I got into this because I like to connect with people and I want to help them through their critical illness, not just because I keep them on a ventilator or give them their medications, but I want to help them have hope, help them be motivated, or help them prepare for death. That's why I love critical care. And that was stripped from me as a travel nurse. And it felt wrong. And so I started asking questions like, hey, this person needs to be up and walking. And I couldn't explain why. I just felt it. It would be more natural to me to get them up and walk them. So I would ask if I could wake them up and get them up. And then the look on the people's faces, the nurses, the doctors that I would ask, 1 of just shock, and then 2 of horror. And they would ask me questions like, well, do you follow them with a cart to replace the breathing tube if it falls out? Like, they were genuinely concerned that if I dared to get a patient up on a breathing machine, that the tube would just fall out. And I had never seen that happen. And now that I've gone to the research, that really doesn't happen. And all I could say was, no, I'm just not going to pull it out when I get them up. So these conversations were really difficult. I would ask, why are they sedated? And they would look at me like I was crazy, and almost like they wanted to check my credentials, right? They didn't believe that I was really an ICU nurse if I was asking, why is this patient sedated? So all they would say to me was, because they're intubated, meaning because they're on a breathing machine, of course they're sedated. And so I realized that in everyone else's minds, it was an assumption. It was automatic. Sedation and ventilators are married. And I could not figure that out. And so it felt wrong, but I didn't really know how wrong it was. I didn't dive into the research. I didn't follow these patients out of the ICUs that I was working in. I didn't see what life was like afterward. I just thought, this is weird. And there's something about a patient's body when it's been laying in bed for so long and the muscle just wastes away, they become blobby, and it grosses me out. Not because it's like nothing to do with them being fat or just squishy. It's just that they don't seem like a human anymore. I don't know how to describe that, but that was just deeply disturbing to me. But that's as far as it went. As a nurse, I just knew that I personally would rather go to the Wake and Walking ICU than where I was working, but I couldn't put my finger on it at the time.
So I'm going to ask you some specific questions about some of the research, and please excuse me if I make an assumption of something that I may have misunderstood as I'm reading this, because I have absolutely no training whatsoever in medical field. So this was all new to me. So I'm going to ask questions that I think are intelligent. Can you talk a little bit about the ICU delirium and what were some of the experiences that the patients shared with you?
Yeah, ICU delirium is a really important concept to understand in this discussion. It helps us understand why sedation or medically induced comas are a problem and why they persist in being a problem. So when we put a breathing tube down someone's throat, we sedate them, we give them medications like surgery to put the breathing tube down. And procedures, surgery, short-term administration of these kind of medications is exactly what they're for, to spare them the discomfort of surgery, of procedures, of those kind of things, right? The problem is that as the standard of care, patients are not allowed to wake up after that procedure. So those same medications that were given just in a quick bolus, just a quick push through the venous catheter, they then start on the IV pump continuous administration of those medications. So they continue those, and that can go on for days to weeks to months, that they're getting the same kind of medications that patients receive in the operating room. And most of us, if not just a lot of us, have had surgery. We've had those medications, and we're so glad that we did, right? We wake up, we're a little loopy at first, and then we move on. We don't remember being cut open in surgery. And so it served a great purpose. Yet the reality in the ICU, when patients are on ventilators under these medications for prolonged periods of time, is that this is not just this sleepy state. They are not sleeping. And the problem is that they look like they're sleeping. They look peaceful. They're tucked in. Their sheets are nice and tidy. Their lines are all in order, and they look so peaceful. And so we have this illusion that the more comfortable they look, the more comfortable they are. But survivors of medically induced comas will tell you that they were anything but asleep, that they were experiencing complete psychosis, hallucinations, terrors. Nightmare is not an adequate word for it because to them it is more vivid than reality. And I've never experienced it, right? Well, this is ICU delirium. And it's not just confusion. It is absolute horror that is more real than anything that else they've ever experienced. But often it involves previous trauma of their whole lives or anything they're afraid of. It just brings everything, all of the scars of their souls come to life, and they have to sit there and face it and relive it over and over and over again while everyone around them thinks that they're asleep. And so later on down the road, when whatever the acute process was, so if someone's on the ventilator for pneumonia or for any other kind of bad infection or stroke or whatever, once that's getting better, so once we can tell that their lungs are better, then we start taking down the sedation because we want to get the breathing tube out. And so from the other side of the bed, right, patients in their minds are running this hamster wheel of terror. We have no idea about it, but we know that when we start taking off sedation, they come out extremely agitated. And these patients are flailing, they're kicking, they're thrashing, they're trying to pull the breathing tube out, they're trying to kick the staff, they're trying to get out of bed. And the interpretation is that the breathing tube is so uncomfortable that no one can tolerate it. No one can be off of sedation on the breathing tube. What is misdiagnosed is that what they are seeing is not just discomfort from the breathing tube, they're seeing ICU delirium. They're seeing what's really going on underneath the sedation, all the agitation, anxiety, discomfort, terror that was masked by sedation. And so instead of saying, wow, this person is really damaged, delirium is a sign of brain injury. So sedation has caused ICU delirium. And instead of avoiding it, when we see that agitation, we turn it right back on because it's quote unquote safer, easier, or more humane. And in our linguistics amongst ourselves and even to patients' families, we use the word sleep. Well, they're sleepy now, or we're going to give them medications to sleep, or we're going to make them go back to sleep, or I would rather be asleep than awake on a ventilator. But these people have spent days to weeks without sleep. They cannot sleep. There's research showing that brain activity under sedation does not resemble sleep. So that's part of why they get so confused and why the brain gets so damaged, is because they are, one, living unfathomable horrors without rest. They're not getting any kind of restorative sleep. And so we just proceed to give them, again, the same thing that caused the problem that we're witnessing. And that's where we get in this vicious cycle in the ICU. And so ICU delirium it can be caused by a lot of things, not just sedation. It can be caused by sepsis, just by being in the hospital. This delirium doesn't just happen in the ICU. It happens on the medical floors. It's very common in the hospital because you are out of your environment. You have an infection that's affecting your brain, essentially your whole body, and you get confused. But sedation alone can cause it. So in my mind, it's not logical that we take patients that are infected, are in the hospital, are at risk of getting poor quality of sleep, are at risk alone of just developing delirium, and then we give them something that will ensure that they develop delirium. It does not make sense to me, but that's what we do.
What was so terrorizing to me when I was reading about some of those experiences was that feeling of being trapped and you couldn't get out of that situation. It was just continuous.
I spoke with one survivor. So she was in the ICU because she attempted to take her life, and she would have these pseudo seizures. And so I went in to go tell her that according to the EEG, like checking her brain activity, they're not real seizures, but I wanted to know what's really causing them. What psychologically has she been through, and why did she try to take her life? And she said that she had come from Puerto Rico, and she had come up a year before and came to the States to live with her son. She had taught elementary school. She was functional. She was living her own life, but she'd gone through a lot of trauma. She had been kidnapped, raped, lived through hurricanes, car accidents, just had a really difficult life, but she was coping with it. She was dealing with it. She was able to still function and take care of herself. But she would have these pseudo seizures, probably related to the psychopathology of that trauma. But she was on the train or bus in the States and had a pseudo seizure. And so the paramedics whisked her away to the hospital. And because they were afraid of her having seizures, they put her on a ventilator. And they sedated her because, and really, sedation is appropriate when people are having seizures. There are indicators in which sedation is actually essential. So seizures are one of those. Yet they did all the workup, and she wasn't having real seizures. And yet she continued to be on the ventilator. And I'm sure because once they realized she wasn't having seizures, they tried to take off the sedation. She becomes agitated. So they turned the sedation back on. So essentially she was probably sedated because she was intubated, and intubated because she was sedated, which probably cost her, she said she was on the ventilator for, I think, 2 weeks, even though she wasn't having real seizures. And she wasn't infected. There's nothing else going on. She was just stuck on a ventilator because they couldn't probably wean off the sedation, quote unquote. All she knew was that she woke up and couldn't move her body. She was so weak and so deconditioned, and she had to go to rehabilitation, really learn how to walk and all those things. But what the worst part was under sedation, she relived all of those traumatic events. Sorry, I get emotional. And it was just so real to her, as if it was the first time happening, but it was on repeat. And not only does sedation cause delirium, but it can also cause post-ICU dementia, or delirium alone can cause post-ICU dementia. So she also left with these new cognitive deficits. Her brain didn't function the same way. She couldn't drive anymore because her reflexes were so much slower. She couldn't do simple math. She couldn't balance her checkbook. She couldn't even use her phone. So suddenly she's got this psychological trauma, and she doesn't have her functional brain to compensate for it. And so she just realized she was going to depend on her son for everything, that she couldn't work, that she couldn't drive, and she didn't want to be a burden on him, and didn't want to live like that, and didn't want to have to deal with that kind of PTSD in the way that she was, because she couldn't cope with it anymore because her brain didn't work. So that was, I think, the second suicide attempt she had within a few months. And she didn't know that she had post-ICU dementia. She didn't know that she had post-ICU PTSD. She didn't know why her brain was this way. And she asked me, why am I so broken? I don't know why. No one has told me. And I just sat there with my jaw dropped and said, you've been totally left by yourself after being severely debilitated from our flawed medical practices, and you're trying to end your life because you have no support. And that's a very common occurrence with our survivors. We're like, woohoo, you have your pulse back, your heart's beating, we did it, pat ourselves on the back, send you out the doors, our job is done. Little do we know that they have this long journey of relearning how to sit up, how to walk, how to talk, how to do anything for themselves again. And even once they physically somewhat recover, the damage to their souls and their brains may never repair.
That's just terrifying and shocking.
I struggled. I mean, the podcast is for the medical community, essentially. I'm on your podcast because I also feel obligated to tell the general public, but I don't want to foster more distrust against the medical community. There's been a big problem with that. And none of this is done maliciously. It's complete ignorance. This is a very complex problem from the ICU side.
Well, I'm glad that you're spreading the word so people can be aware. And when they enter into a situation where they may need to make a decision as to their care in an ICU, or if their family members need to make those decisions, that they are aware of all of the different options that they may have or what the effects of those options will be.
And they have a right to know. And we've done a terrible job of being transparent with families and patients, in part because the ICU side themselves are unaware. When someone goes in for a surgery or for any kind of treatment, there's this whole waiver, and we explain the risks and the benefits of the treatment and let patients decide for themselves. And we say, this is important that you have this surgery, but these complications may occur. But when someone is facing a ventilator, we say, this is what's going to keep you alive. Sign here. We don't say, would you prefer to be in a medically induced coma or would you like to be awake? And here's what it means. If you are in medically induced coma, you're at higher risk of dying in or out of the ICU. You're at higher risk of infection. You're more likely to spend more time on the ventilator and in the hospital. You're more likely to be discharged anywhere but home, most likely a care facility like a nursing home, rehabilitation center, and that could be for weeks or months. You're less likely to return back to your job. You're at high risk of developing post-ICU PTSD, post-ICU dementia. Your life may never be the same again. Or you could be awake and it might be a little uncomfortable. We can treat your pain and anxiety. Your family can be present. You can communicate with your family. You can be aware of what's going on. You can make your own decisions. You can stay strong and functional, get off the ventilator sooner, and go straight home from the hospital. Sign here. You choose. We don't do that.
Why not? Why aren't hospitals allowing patients to make that decision?
The hospitals themselves don't know. Again, sedation and ventilators are very, very intertwined and married. And that's my mission, is to divorce them, to make us stop and ask, is sedation actually essential? Sometimes it is. Again, I use the example of seizures. When people have hemorrhagic strokes or brain bleeds and their brain's swelling and you don't want them to move and increase pressure, that's when it's essential. If someone has some sort of drug toxicity and they really are a risk to everyone around them and themselves, that's essential, but we've got to get it off ASAP. So there are situations in which it isn't essential. I don't want to say that sedation should never be present in the ICU, because that would not be safe either. But if we have these honest discussions and if everyone, especially the ICU community, was aware of the repercussions of deep sedation, then we would weigh the risk versus benefit completely different. And the family and the patient should be involved in that discussion. But I think the problem is that the ICU community just doesn't know. They don't know that it's possible to walk patients on ventilators, let alone that it really should be done. And there's this mentality of the sicker someone is, the more they should be in bed. It kind of goes back to, these old grandma myths, right? Don't rinse your hands off with cold water after ironing, right? It's very cultural. And yet in other parts of medicine, we've evolved. After surgeries, people used to be bed rest for a long time. And now it's wake up from surgery, get up out of bed. Women used to be bedbound after childbirth. Now it's the complete opposite, because we noticed that they were having blood clot and developing pneumonia, and it was impacting their survival. We have plenty of research validating this approach in the ICU, and yet it's not common knowledge. And so therefore it's not common practice yet.
I wanted to touch a little bit more. We didn't really get into the post-traumatic stress, and I think that's an important area. Mm-hmm. So why has the ICU-induced post-traumatic stress disorder been so largely unidentified and untreated?
I think there are lots of gaps in our system, and this is one of the big ones. I think it comes from awareness in the ICU, where ICU providers really think, especially nurses, deeply believe that giving sedation is sparing patients PTSD. They deeply believe that it's going to be so traumatic to know that they're in the ICU, to know that they're critically ill, to know that there's a tube down their throat, that they are being humane by putting them in a medically induced coma, right? So I think we think that because they weren't present, because they weren't with it, that they didn't experience any trauma, so they're going to be fine. We just have to work on the bodies. That's all we care about, right? We're just looking at specific organs. And we love our numbers. We love seeing numbers on the screen, numbers from our lab results. The brain doesn't give us numbers. If so, it'd be really nice to say, these numbers show that this patient has delirium and therefore they're at risk of having post-ICU PTSD. It's becoming more common to screen patients for ICU delirium with a tool called the CAM score. Yet even when patients are CAM positive, even when we've identified that they're delirious, that doesn't raise any red flags to provide follow-up care for after the ICU. But if a patient has a kidney injury or they have dysfunctional lungs or any kind of residual physical effects from their ICU stay, as a nurse practitioner, I set them up with pulmonologists, nephrologists. We have all these specialists that we send them to, but it's been becoming more of my practice to try to set them up with mental health resources as they're leaving. But that's not the standard because we're grossly unaware that we have injuries to the brain and to the psychology of patients. So I think that's one problem. Another problem is that primary care isn't aware of any of this either. So patients or survivors are going to their primary care doctors and saying, hey, I don't know how to explain it, but I can't do math. I can't remember things. I can't read a clock and I can't sleep anymore. And what I'm hearing from survivors on survivor pages is they're being dismissed because on paper, look, your kidneys got better, your infection's gone, you should be fine. Move on with life. That was probably a rough ride, but just move on. And no one is saying, hey, you have suffered a brain injury. You have cognitive deficits. You need neuropsychology to help you work through the PTSD and the cognitive dysfunction. They have no idea. And so they're not set up with the right resources. And there's a growing movement and development of post-ICU clinics, which I am so excited for. We don't have a lot of data showing how effective they are, but even if they don't completely reverse the damage that's been done to patients, if anything else, there'd be validation. Patients that actually could connect with providers that believe them, that say, I know what you've been through, or I understand and I believe that you're traumatized. Patients on these survivor pages are talking to themselves and desperate to find anyone that will believe them, because the families will say, no, you didn't get raped. You didn't get raped in the ICU. So stop talking about it. And they said, no, I experienced that, but it doesn't make sense to them. And they ask, why do I have this nightmares? I know I was in the ICU, but that's not where I was. So other survivors will say, me too. I experienced that too. And these were my experiences. And this is what I'm feeling. And if anything else, they just feel validated. They don't feel so crazy. But from their loved ones, from the medical community, they're completely dismissed because we didn't see it. We saw them in the bed and they saw themselves having genital mutilation. I mean, there's a huge disconnect all across the board.
I thought it was interesting when I was reading some of the information in the articles that you had written, and you shared a story about a man who was in a post-traumatic stress disorder group, and he had been in the ICU, and he said that at some point he had made the decision that he would rather die than go through that experience again because it was so traumatizing and so traumatic for him when he was in the sedation.
He was an extremely important survivor to me and hopefully to the rest of the medical community now. I met him when I was in grad school and I was still working as a nurse, and I met him on a plane. And I told him what I did for a living. Told him I was an ICU nurse, and the color just dropped from his face. And he tried to tell me what he had experienced. And up until that point, I'd worked in the ICU for, 6-7 years. I'd never heard from a survivor, from anyone that had lived it, what ICU delirium was like. And he didn't use the words ICU delirium. He had no idea what that was. He had no diagnosis, no validation to what he had experienced. But what he was telling me was that he vividly lived the reality of having his limbs nailed to the ground in the middle of a forest, and trees were falling on him, and monsters were coming out of the sky. And I know that there was more, and I could tell it was hard for him to talk about. And this is about 4 years after the event, and he could still barely talk about it. And he wept to a complete stranger on the plane. And he talked about the following year after his discharge, rehabilitating physically was hard, but not the hardest. But it was hard. The hardest part was every time he closed his eyes, those images came back to him. And I'm sure they weren't just images. It was like he was sucked back into that world again. And it was so much so that he could not sleep. He spent a year being unable to sleep, and he went into a complete psychotic spiral. Remember, he's in his 40s, mid to late 40s, and he ended up divorced because his wife at the time had slept on the floor of his ICU room, was so good to him, as he said, but he wasn't himself anymore, and she just couldn't do it anymore. And he expressed such a loss at that. He hadn't been able to go to work again. I didn't know enough at the time to ask, hey, how's your cognitive function, right? But I'm sure he had post-ICU dementia as well, because he had been in a medically induced coma. And he said, nothing else is wrong with him. This was a fluke that he even ended up in the ICU. He had no comorbidities, nothing chronic, but he said, I'm a DNR, meaning I'm a do not resuscitate. And I think he really means I'm especially in a do not intubate. Don't put me on a ventilator. He said, no matter how reversible my condition is, I'm not stepping another toe into an ICU. I cannot live through that. And he said he felt guilty. He felt like saying these things made him ungrateful for surviving, but that his time in the ICU had ruined his life, and his life was not anything like it was before. And that's really what spurred on a lot of my research and my advocacy were his words. And then I got into these Facebook pages, and he is not the only one. I wish I'd known at the time that there were support groups, because now when survivors reach out to me, I say, come talk to the survivors, and they find so much solace, even just knowing that they're not the only one, that they're not crazy, that this is a thing. And they're like, Vanderbilt has an incredible post-ICU support group spearheaded by psychologists, but also by survivors themselves. And they meet, even now, they meet over Zoom. They meet with people all around the world just so that they can have someone understand what they've been through. Because from the outside, from someone that has not been through ICU delirium, it didn't happen.
Yeah, if you're not being validated by the medical community, then you start to question yourself. But when you get the support of other people who have gone through it, I'm sure it can be very validating and something that a lot of them, unfortunately, may not even be able to experience if they don't even realize that those support groups are available.
Or if they don't even realize that this is PTSD, or they don't realize that this is depression or anxiety. They don't know that they're panic attacks that they're having. They just know that they can't leave their house. They just know that suddenly they feel like they're back in it. They hear a sound and it reminds them of the ICU, but they don't get drawn back into the ICU. They get drawn back into their hallucinations. So those events that were hallucinations are as much as real to them. And I think if we understand that they're real, they're not just nightmares, they're not just a figment of their imagination, it was real, and we need to treat them as such. So some survivors are doing EMDR, just treating it as real trauma, because it was. One survivor, I interviewed him on my podcast, Spencer. He had horrific ICU delirium. And beforehand, he was an attorney, podcast host, stand-up comedian, and can't do any of that anymore. So he has a very different calling now. He helps with these survivor groups, but he will forever now have a beard. His therapist had invited him to keep a beard because before the ICU, he did not have a beard. And so when he gets sucked back into his delirium, when he has these flashbacks and gets lost in his mind, whether it's in his sleep or it's in any moment sporadically during the day, he can feel his beard and it brings him back to that year and that reality, because in the ICU, he didn't have a beard. He didn't have a beard before the ICU. So it's a grounding tool for him, which I thought was incredibly revealing as to how powerful this is and how lost they get in their hallucinations and their delirium, even years after.
What would you like to see happen? What changes would you like to see in the medical community that you think would help this situation?
Oh, so many things. I would love for the ICU community to be aware, for them to know if it should be part of our education. We study side effects of medications all the time. We know if someone has a kidney injury, we're going to adjust medications so that we don't hurt the kidneys more. But when it comes to sedation, there's this mentality of the more the better. So if I could just get people to just wake up and know, so that they can decide whether or not they want to administer that liquid PTSD or not. If I could get it to be that vivid for them, then it would really change the way we practice. If we could just hesitate before we did it and ask ourselves, is that really essential, or are there other things we can do to realize that sedation does not make anxiety better? It makes it worse. It creates it. If there was education on the side of the healthcare field, I'm thinking about a medical case that I'm reviewing right now. I also do legal consulting on the side, and I'm working on a case that's for wrongful death from sedation. And the nurses document very clearly that this was that these medications were for the patient's comfort. Despite the family advocating for them to stop those medications, they kept saying, no, this is helping them, because it looked like that. And so if we could just go in that moment, right before they administer it, and say, hey, they are anxious and agitated because they're terrified, because they're delirious, do not give them more medication that will make them more delirious. So I think that would be a start for the ICU community to be aware, to stop the marriage, to divorce the marriage between sedation and ventilators, so that patients are allowed to wake up right after intubation and be themselves, so that the ICU community can see that they can be cooperative and calm and directable when they don't have days and weeks of sedation trying to metabolize out of their bodies and sleeplessness plaguing them. That would make care so much easier for the patient and for the ICU team. Delirium is extremely laborious. It's so hard to keep someone safe when they are trying to pull out their breathing tube and trying to get out of bed. So if we get the whole ICU community to just let patients wake up and get them out of bed right away so they don't get so weak that they can't walk, then I think we'll have a huge culture change where it's normal to have patients be awake and walking and stay functional, get the breathing tube out faster because they can breathe on their own. Side note to that, one of the other things, we talked a lot about the PTSD and the psychological effects, the mental effects of sedation. But when patients aren't moving on the ventilator, their muscles just atrophy. There are studies showing even normal, healthy adults in one study in their 20s, a bunch of young men in their 20s, they did bed rest, which means they could still change the remote, be on their phones, shift themselves in the bed. But they sat in the bed for a week and they lost like 2.7 kilograms of lean muscle mass just from bed rest. And so when someone's acutely sick, when they have critical illness, their body is in a hyperinflammatory state and they're going to be consuming more calories, more muscle quicker. And then you have sedation, which can directly affect the muscles. And then you have immobility, where patients can't even lift their own fingers, right? There's a complete disconnect and atrophy of the muscles. And so that affects how patients can get off the ventilator. The respiratory system isn't just the lungs, but we don't have that perspective in the ICU. We just see it as lungs. So the lungs are sick, we're going to put them on a ventilator. But the brain and the muscular system are part of the respiratory system as well. So when we damage the brain, when people are too confused to even, or too sedated, too sleepy to even take their own breaths, and then too weak to drop their diaphragm and inflate their lungs, then sure, the infection can be better in their lungs, but then they still can't breathe on their own. So then they're going to need the ventilator for a lot longer. And that's why we end up doing these tracheostomies most commonly, is because patients have become too weak to breathe, not because they're too sick anymore, but because now they're too weak to breathe. So they give them a tracheostomy, they send them to rehabilitation and then they can clean up the mess and try to get them strong enough to hold their own head up again.
Yeah, you had an interesting quote in one of your articles, and it said that sedation is not sleep and immobility is not rest. So you've really touched upon why the mobility was so important. And it's interesting because, as you mentioned earlier, we're getting women who have just given childbirth up and out as quickly as possible. We're getting people who have even major surgeries now up and out as quickly as possible. It seems like this particular area of medicine hasn't been as quick to embrace that mobility issue.
And it's hard because critical care is complicated. People come in and they are so sick. And sometimes they come in and they're already delirious. They're already encephalopathic. They already are confused. And we like to see them comfortable and tucked in. And COVID has been a huge problem, in part because there are so many patients on ventilators and their lungs are so sick that it makes us even more scared to move them, right? If patients require a certain amount of support on the ventilator, that is deeply impactful. It impacts our fear. So if their settings go up, then our fear goes up. And we feel like if we can't move them, if they're getting so much oxygen or so much support from the ventilator. But in the wake and walking ICU, it's kind of the opposite. It's, wow, their lungs are getting worse. Their ventilator settings are going up. So we better move them more because that's beneficial to their lungs. And they're going to need their muscles to move stiff lungs. And they might get to the point of having to be face down and paralyzed, but they're not there yet. So we got to hustle them. We got to keep their muscles strong so that when they get to that point, you don't start from a totally deconditioned body when you take that break for paralysis. And so it's a huge misunderstanding.
I was just thinking in terms of our medical system and how isolated we are to parts of the body. We see a gynecologist for women's issues. We see an ophthalmologist for eyes, or, the ENT for our ears. And it's almost like people are so immersed in that one area of the body, and they don't see the body as a holistic unit that's so intertwined and so interconnected, and how important that is to our overall health and our recovery if we are sick.
And I think that can be exacerbated by our interactions or lack of interactions with patients when they're on sedation, when they're in medically induced comas. You can't know who they are as a human. And so there's a lack of humanity. And people get into critical care because they love humans. They want them to survive. They want to help them. They want to save lives. But you don't know that person. So you don't know. I mean, to me, it's important to know, what did they do for a career? What do they enjoy to do? What are their family dynamics like? It helps guide what kind of things. For instance, one COVID patient was a golfer, avid golfer, but COVID was really rough on him, as it is with so many people, and he didn't want to get out of bed. He didn't want to move. He was just so tired and so despondent, and it's terrible not to have the family in there. That alone is inhumane, because that is their grounding point. So when they're battling delirium, you have to have a familiar voice and face, and he didn't have that. He wasn't delirious, but he just was, you could tell he was kind of giving up. So I see the physical therapist walking in with a cane and a bedpan, and I knew he didn't need a cane. So I asked her, what's going on? Nor did they usually need bedpans. They usually, even on a ventilator, can get themselves to a toilet and wipe their own backsides. Side note for humanity, who doesn't want their own dignity to wipe their own backside, right? Anyway, so she's walking in with a cane and a bedpan, and I asked her what was going on, and she said, we're going to golf. I know he likes to golf, and I can't get him to do anything else, so we're going to golf. She knew that because she could ask him. I don't think she'd really even talk to the family over the phone. but she could ask him, hey, what are you into? What do you like? Okay, we're going to do some golfing. That would get him to get out of bed, stand, golf, have some sort of diversion. So I think it's easier to see the people as a whole and as a person when you can look in their eyes and you can talk to them and you get to know them. So in the ICU, you have organ failure, you have a very specific organ that's sick, and we get fixated on that. Man, they've got liver failure, the liver's sick. But you're right, there's this huge disconnect because the body is very intricately connected to itself. And I think the brain especially gets the short stick of all of this.
Is there anything that you haven't been asked that you wish a host would ask you about this topic?
I feel like you've asked me such good questions that no one's asked me before. And we've kind of touched on it. I think one of them would just be, what now? For me, that's a question I'm asking myself all the time. I have had a hard time imagining working anywhere else. I had to move. I had to change locations because of some needs for my family. My daughter has had a lot of health problems and we need to be closer to family. So I had to leave my beloved Awake and Walking ICU. And man, there's a comfort zone of just knowing that you're walking into people that share the same vision, that are doing amazing things. I take no credit for the Awake and Walking ICU. I just am taking notes, right? That's what how the podcast started. I just started interviewing them. They've done this for almost 30 years. They are my mentors, right? So I just felt very comfortable just knowing that things were going to happen. It was going to be good. And I was going to ethically feel comfortable there. And my values were in line with theirs. No, it's okay. So in my new location, the job wasn't necessarily open yet, but I interviewed or toured this hospital and I sat down with this group. And this was actually before I moved here. The podcast was just an idea. And I tried to tell them, I can change your outcomes. I can get your patients home from the hospital. I can get them up and walking on the ventilator. And they just looked at me like I was speaking French. They had no idea what I was talking about. And they just shut me down right away. They said, you can't do that. Of course you have this. Well, what do you use for sedation? And I said, we don't usually sedate, but if we have to give something for anxiety, we use these medications. And they said, oh, so you're sedating them. I said, hardly ever are those medications used. And if we do, we don't do it so they can't even open their eyes. So anyways, it was a very unproductive conversation and I left very discouraged and thinking, where else could I possibly work? I don't want to go somewhere and feel so alone and also feel conflicted. I felt sick touring this ICU because it was dark and dim. And now that I've done all this research and spoken with survivors, how do you see someone in a medically induced coma and not hear the voices of the people you've talked to sharing their trauma? How do I allow that to happen where I'm working? So I've had to be transparent. If you hire me, it's to change things. I'm here to change things. Let's take it or leave it. So I think that's very hard for people that have been listening to the podcast. They're reaching out and they're saying, I believe this. And now it haunts me. And someone said, I could only make it, 5 episodes in. And I had to take a break because it made it really hard to go back to work. I listen to these things on my way to work and then I walk in and I'm seeing all these things that I now know are hurting people. And yet I'm a physical therapist. I'm a nurse. I can't change all these things, which I dispute that because the Wake and Walking ICU started with one nurse 30 years ago with no research or evidence or anything behind it. So I know that anyone on the team can bring the change, but it does have to take collaboration. But even myself, even after all this experience, I have trepidation going into a team and saying, all right, I'm going to tell you something that's going to sound crazy. The world is flat. You know what I mean? And so now I'm doing webinars. People are sending me in as the hitman to present to their ICU teams and to show case studies with pictures, videos, stories. And I just refer back to the podcast because I have 71 episodes on it. It's a very complex and vast topic. So that's been really exciting. And I hope that locally I can go back to that hospital that had shut me down and be a consultant. And my dream would be for someone to call me from the hospital and say, hey, we've got someone that's about to be on a ventilator. Can you come? And just to hold the patient and the team's hands as we wake that patient up, and just so they can watch them be calm and cooperative and right on a board and show that they can still be human on a ventilator. Help them get up, help them walk. I would just love to be part of a culture change, not just through a podcast and the big picture, but just the intimacy of being at the bedside. But I don't know if I can ever go back to being a normal nurse practitioner unless I can practice the way I know is right.
So are you a clinical nurse right now? Are you practicing in a clinical setting, or are you doing
I'm
more?
Not somewhat. I feel like I spend a lot of time in the hospital, but mostly with my own daughter. She has a lot of health problems, care problems. And so we're just working through a lot of that. But I'm hoping to be at the bedside, hopefully as a consultant in the near future.
Well, that's what I was going to ask. Perhaps your calling now is as an educator and bringing awareness to people and doing education and consulting more so than the actual practicing of the clinical
I would love it. And I've been advised to go more to the CEOs and risk management, that this would have to be something obligated from above, because ultimately it costs so much money to break people, essentially. So I've been approaching this from a place of compassion, humanizing the ICU and sparing suffering and harm. And I think it's going to have to be be with a dollar figure, unfortunately. But I think if hospitals were willing to hire more people to provide support, education, they would save so much money. So hopefully I can hit it throughout that angle and still be able to bring in the compassion.
Well, you're spreading an extremely important message, and I appreciate you taking the time to make my audience more aware of this. Is there anything else you'd like to tell us about you or your work?
Nope, this is not to demonize anyone. I've been on many sides of the healthcare fed. I've been in it. I've been the nurse practitioner. I've also now been a family member. And people go into healthcare because they want to help. They are some of the best and kindest and most angelical people among us. And so none of this is to foster distrust, but just to spread awareness that there needs to be a change and it is coming, and that we can work together to make that happen, whether you're the patient, the family member, or the healthcare worker.
And where can listeners find out more about you?
They can check out my LinkedIn. They can look at the podcast. It's called Walking Home from the ICU. It's on any of the main podcast platforms. And then my website, criticalcareconsultant.net, is going to be up and running soon. And that I would love for someday soon for it to have a side for family members or patients themselves to help them work through that process while they're in it. But I'm going to start with the healthcare side first. But I'm happy to chat with anyone that has any other questions, but listen to the podcast all the way through if you dare. And then I'm happy to answer any questions after that.
So the website is criticalcareconsultant.net.
Correct.
And the podcast is Walking Home from the ICU. And if you Google that, you can find it everywhere, as I did.
Yep. And I have other interviews in other places. I just recently did an interview with Critical Care Scenarios, and we did a case study, which I thought was a great format to have real application of these principles. And it was a real patient. And I have her pictures on my Instagram and Facebook. The podcast itself has accounts that have lots of pictures and videos from the Wake and Walk in ICU, but as well as hospitals around the world that are doing these things. People are sending me their success stories. And this is not just, it almost seems like Brazil is doing this more commonly than anywhere else, to be honest. So this is going to be standard of care throughout the world. And America is not the most advanced with this.
Well, hopefully by spreading your message that we can catch up with some of the other countries in the world.
Hopefully someone's got to say it.
Well, it was great to have you on the show, Kaylee. Thank you so much for taking time to be a guest on the Curious Professor podcast.
Appreciate it.
And now for the answer to this episode's trivia question. How many patients stay in an intensive care unit in the United States annually? According to the New York Times article, Nightmares After the ICU, about 5 million patients stay in an intensive care unit in the United States annually. We'll end the show with something punny. Why did the banana go to the hospital? Because it wasn't peeling very well. Thank you for joining me for this episode of the Curious Professor podcast. If there's a person, place, artifact, or natural wonder that has sparked your curiosity and you'd like for me to feature it on the show, please let me know. My website is thecuriousprofessorpodcast.com. If you enjoyed the show, be sure to subscribe to the Curious Professor podcast wherever you listen to podcasts. And if you'd like to become part of my community of curiosity seekers, be sure to visit my website, thecuriousprofessorpodcast.com, and join Dr. B's Hive. Until next time, always be learning and be curious with Dr. B.